Well, thank you everybody for joining. I want to just welcome everybody to the Health Equity Finalist Spotlight. As a lot of you know, this is our seventh annual Digital Health Awards show. So we're really excited. I am honored to be joined on this call by Matthew Holt. He is one of our executive producers and a founder of Healthcare Blog and Health 2.0 Conference, as well as Kirk Barnes, who I had the privilege of chatting with for a few minutes before we got started on this. Kirk is a SuperConnector and a co-founder at TransPharMed. So today you're going to hear directly from a lot of our standout finalists in this category. They are companies that are helping shape the future of healthcare across the globe. So with that, I would like to introduce Jason, who's one of our sponsors and partners this year, and he's gonna kind of walk us through a little bit of what he does. And take it away, Jason.
Nice to meet you all. I'm Jason. I'm the head of insights at CB Insights. We do, as the lovely screen or slide on the screen now says, predictive intelligence on private companies, right? Really trying to provide as much insight and intelligence on how people find, partner with, invest in the best companies and technologies that will define the future of, in this case today, healthcare and health equity. Right, we're a partner with the Digital Health Hub, and then we're also partnering with Health at the conference itself as the predictive intelligence center for the conference, hopefully helping everyone navigate the conference, understand who they're meeting, who they want to meet, and what to do about it before, during, and after, just that little bit better. So happy to be a resource leading up to the conference, happy to meet a ton of you while we're there, and then happy to share some of the insights we have on the health equity space. And again, I have to give this disclaimer every time we jump on. Please ignore 2021. Uh, this is what it looks like for pick almost any market across any sector. Right as we ended the ZERP era, when money was apparently free for VCs and they wanted to pour it into pretty much anything. If we start to look at sort of the sustained levels of funding for the last few years, and a little bit of a lull this year, I think a lot of that starts to represent itself as more of an opportunity where investors are looking for the companies to deploy that capital into, rather and specifically looking at the AI applications across health equity. Right when we start to look at some of the segments that are still driving this funding and driving a lot of the right, if you look in on these bullet points on the market segments, are seeing high average mosaic, which is our proprietary company success probability metric out of 1,000, right? Anything that sits with a market average over about 550, we classify as one of the leading markets, right? Ends up in the upper decile for any market. So we see that virtual pediatric care, employee benefits navigation, and virtual doula support all end up in that upper decile, right? Interesting to see that a lot of these health equity markets end up overlapping with many of the other categories, being childcare or kids' health, and then the women's health and maternity segment for the virtual doula support. And then, oh, apparently I lost some of the bullet points on the competitive dynamics that go under the chart, but I'll comment on those after touching on the tech and business model innovation, right? Unsurprisingly, I could sit here and just wave my hands and say AI, and we'd all nod along saying, yep, that's changing everything. And then we start to look at some of the ways that that's delivering the most value already in health equity, getting healthcare in a more personalized manner to more people, and then thinking about the ways that it is changing the business models to be more targeted at value-based care alignment, and then really figuring out, almost at a policy level, or from the policy level and from the sort of ground up, grassroots, thinking about the social determinants of health and how things like connection, things like blending consumer and clinical care, and translating data between all of those will start to impact the accessibility and equitable distribution of health outcomes. When we look at the competitive dynamics, right, we see that there's a massive amount of involvement from the incumbents actually investing in this space, right? So you see a lot of the providers and networks like United Health, Kaiser, etc., starting to look at technologies and ways to distribute health uh, accessibility more evenly. And then we're seeing, unsurprisingly, a massive wave of AI first, digital first startups building equity as their core value prop versus sort of trying to pick at it piecewise. With that, I'll start to hand it back all over to talk about a lot of those digital first startups building equity from the ground up.
Cool. Thanks, Jason. I really appreciate it. Now I get to introduce Kirk. He's someone who brings a unique lens to the conversation. He works with a deep healthcare, has a deep healthcare expertise with a sharp eye for transformation innovation. We're very honored to have him here with us, and all you, Kirk.
Thank you. Thank you. It's great to be here, and congratulations to everyone for being here so far. Kirk Barnes, I am very excited to be here in this category, especially given the current environment that we're in here in the US. So, spent a first part of my career in the pharma biotech space, went to a nanotech spinoff out of Northwestern, and then ended up launching the first health tech program at Georgia Tech's incubator here in Atlanta. And very exciting for the last 3.5 years, I was co-chair of an organization called Together Health, which is one of the largest digital health ecosystem consortiums in the country. This is near and dear to my heart, obviously, as we actually had a health equity subcommittee that was a part of Together Health. And for the last 3.5 years, I led a startup initiative within the U.S. Department of Commerce that was specifically geared at helping the underrepresented with a focus on healthcare as one of the verticals. So the great thing I love about this category is it truly blends not just technology and health, but the impact in making sure that healthcare can be leveraged and positively impacted no matter what your socioeconomic status is, no matter where you come from, no matter where you live. And so the work that you're doing is extremely critical, is extremely important. And technology just happens to be one of those tools that can be used to deliver health equitably across the nation and across the world as well. So very excited to be here. Please connect with me on LinkedIn if you're going to be at Health in Vegas. I look forward to seeing you there. And again, congratulations on making it here this far.
Fantastic. So it's time for me to take over. I am Matthew Holt. I am one of the executive co-chair producers. I can remember the name of the actual name that Mark bestows on us at the Digital Health Hub Foundation for the awards show. I think it's been a while now. I was there back in the early days when it was in a relatively small conference room at UCSF. Then we had the fun and games of the pandemic when we weren't allowed in the conference room while the award show was going on. And since I moved to Vegas, it's become quite the thing. So we're looking forward to having various of the awards distributed over various stages at Health all across Monday afternoon. But this is one of our precursor shows where we highlight the finalists. In this case, the category is the health equity category. And unlike some of the other hour-long sessions, we've got the luxury here that we only have the best-in-class group. So we only have four companies here. So we get to know them a little bit. Those of you who are on the AI group, as far as I can tell, Mark had to get through 25 companies in 55 minutes yesterday. So everyone got 12 seconds each. So you guys had the luxury of taking rather more time. So I'm looking forward to a couple of things. One is to hearing quite a bit about your companies. You have a little bit of time to tell us about them and tell everyone else. And the other thing is to have a bit of a discussion amongst us, led by Kirk, about where we're going with health equity and how it matters. Because obviously, as he alluded to, the vibe has changed somewhat, not necessarily for the better, I would say, in this country lately. But to start off, we're just going to do a round robin, and I'm fascinated to hear from all four of you, not only what does your company do, but specifically, why are you in the health equity category? Because in fact, you all do something a little bit different. So I'm going to introduce you, and please you'll take it up. And we'll start with Hao Liu. Hao is the Chief Medical Officer at Cylinder Health, which I knew back in the day, and I still have a T-shirt from, I think, when they launched at Rock Health in 2017, 2018. And the T-shirt said, let's talk about shit. But now, it was called Vivante. But now it's called Cylinder Health in the IBD, in the gastro world. So Hao, please take it away.
Thank you. Thank you so much, Matthew. And thank you everyone here, and we are just on behalf of Cylinder, or as you mentioned, Vivante. I and our team are very excited to be able to participate, especially with this august panel. I guess what I would do first is, if I understand it, just talk a little bit about what we do and why we are in this category. So for folks who, as Matthew alluded to, we are in the digital digestive space. So we are a digital digestive care management provider, where we work with employers and health plans to serve their members and employees regarding a wide range of chronic digestive issues. That's often can be Crohn's disease, that can be irritable bowel. Lots of times people don't have a diagnosis and they just don't feel well. It's a widespread problem. 40% of the population have an issue every day. From when we talk to employers and health plans, it's now the third highest area of spend, and it is the second highest in terms of trend. At least that's some of the data out there. So really trying to support members because there's such access issues. Within GI itself, and why this is an important question from health equity is because there are known giant kind of disparities in care. For example, Black Americans have the highest kind of comorbidity and mortality associated with colorectal cancer, yet often have the lowest screening. Hispanic people have the highest rates of liver disease, and yet often don't get the care they need. So the question is, how can we deliver the appropriate care to these members? How can we close those gaps? We've had the privilege to take care of over 100,000 people. We connect them with virtual RDs, registered dietitians, health coaches, gastroenterologists, as well as a robust kind of online platform with education and courses. And the reason that we are really excited about this is because we build our product to close these disparities, whether that's by providing it access, and that's through the internet or through phone, culturally sensitive content. That could be the reading level, that could be culturally sensitive recipes in our case, and then longitudinal relationships where maybe they didn't exist before. The reason that we're particularly excited, I want to share some of our outcomes. We published 2 papers in peer-reviewed publications, one last year on looking across socioeconomic variables. Specifically, we use something called the Social Vulnerability Index, which is a CDC measure, basically looking at various aspects of social determinants of health. And in BMJ gastroenterology, we were able to show that we had excellent outcomes across all socioeconomic, racial, gender groups, and we're very excited about that. This last month, we just published another paper in JMIR that looked at high social vulnerability, that is people with poor SDOH, and we found that when they had a longitudinal relationship, that is where they didn't have that relationship before, they had 22% better outcomes than those in terms of clinical digestive support, better outcomes than those who didn't have those types of longitudinal relationships. So that was something that we just published this month. So to summarize, and I think we said 90 seconds, my apologies if we've gone a little bit over, but central to what we do as a product and as a service, they're widespread, as I mentioned, healthcare disparities, particularly in gastroenterology, and our goal is to address those issues, provide care for all those who need it. I think the final question was like, well, what about the current environment, and how? Like, we will continue to think about that because that's the way that our service is delivered. We want to take care of all those that we have the privilege to be able to help, and so that's central to our thinking and our approach.
Fantastic, Hal. That's great. And I think as we go through this, we'll see that there is important health equity components in not only service delivery, virtual delivery, the way that you guys are doing at Cylinder, but also in lots of other different spheres of this. And it goes without saying that access to care and treatment during actual care has been very varied over different ethnic and racial groups in America over the last several hundred years, and it's still a massive problem, as we know. So it's great to see how you're doing in that area and how you'll bake it in to what you're doing. All right, next up is TaylorMed. Shulik Dvorsky, I hope I got your name right. Shulik is the CEO and co-founder. And you guys are doing something rather different. You're looking at the ways that people can get access to financial support for their care. So take it away.
Thank you. And you pronounce it well, so thank you for that. I appreciate it. Usually being featured, so yeah. So first of all, thank you for the opportunity to share more about us and for the honor of being selected amongst those great leaders and companies here. So TaylorMade, to your point, Matthew, is tackling access to affordable care as kind of its core mission. And we have decided to focus all of our efforts around medication affordability. So the company has been kind of growing from the early days, focusing on specific therapeutic areas like cancer, where a lot of patients are going bankrupt in like immense, I would say, proportions to general public. And I remember when I started the company, learning about the term financial toxicity and the fact that more than 2.5x patients are going bankrupt if they're with a cancer diagnosis. It's kind of the reason we started the company. But since we did that, we have grown to look at every medication encounter that patients have, regardless of their condition, regardless of their kind of site of care, and also recognizing that while patients are struggling to afford their medication costs, there are a lot of other resources of funding and support that they can tap into, but there is a gap that kind of prevents them from doing that. So recognizing that you have the patient at the center of all of that, you have other stakeholders, whether it's their health system, their specialty pharmacy, their infusion center, the life sciences companies, and other stakeholders that can provide funding and support. We decided to tackle that as a network approach and started to grow and connect to many different organizations to now having our platform, which is basically an end-to-end software solutions that help patients with out-of-pocket cost for medication, connect with third-party assistance programs automatically. And we created a network that connects all of those stakeholders together. So the platform is now deployed across more than 900 hospitals, 3,000 clinics, and 1,500 pharmacies, reaching more than 15 million individuals a year that are on specialty, high-cost medications, branded medications for their chronic conditions, and so forth. What we do in a very kind of simple way is we get data straight from the IT source of truth, which can be an EHR. We look for available assistance, and we automate the very complicated process of checking eligibility for programs for patients based on their zip code, their income, their diagnosis, their insurance type or lack of insurance in many cases. We then help them with the enrollment, realization of those dollars. And what we've done is that we've been able to connect all of those stakeholders together and really like increase the utilization of available assistance to those patients. So just to quote a few stats, like last year alone, we reached more than 100,000 patients who got about $10,000 on average through third-party assistance. And some of those patients are the most underprivileged, underserved individuals in the country. So the fact that we have this widespread network, we see patients in rural areas, we see patients who cannot afford a $300 out of pocket for their kind of chronic condition. And amongst the patients that we served, about 115,000 patients are low income. About 93% are less than 400% of the federal poverty level. And about 40,000 that we've assisted last year have been uninsured patients. And when you think of all of that, you are not only bridging the gap between patients who can't access medication because of cost. Once you solve that critical need, you have the opportunity with digital tools to start unlocking other solutions to access and adherence. So once you have the patient on a therapy, now how can they reach their infusion site if it's 300 miles away? So we are supporting them with transportation assistance. Some patients are able to afford medications, but they can't afford their housing. So we have living expenses and nutrition assistance. And when you think about this category of health equity, it is all about the impact of the episode of care on the patient's life. And can they get access, but can they stay on therapy? And we're trying to look from the point of prescription to first fill to ongoing care. How do we remove all of those barriers with this platform and solutions that we've created? So again, really privileged to be here. That's what we've been doing.
Thank you so much. And again, that's another great issue. And as we know, the costs of cancer care have been and other medications have not got any better. So this is a great solution to help patients who really need the help. All right, next up, Calvin Chan. He is the CEO of Nirvana, which is similarly in the business of sort of trying to help people figure out the craziness of the system, which which is something we all need. Calvin.
First of all, thanks for having us. And yes, you're right. We're in a similar space, and I'm excited to share the stage with everyone here. Usually, what I start out with is a question, which is think of the last time you went to see a doctor, and the front office staff, they called you, they told you they accepted your insurance. How much did you trust that statement? And most people would say no. And that's actually one of the most fundamental issues in our healthcare system today. We struggle to answer two basic questions when we see a doctor. Am I covered by my insurance? And two, what will this cost me? And when those answers aren't clear, everyone loses trust. And so ultimately what this means is, one, we avoid care because we're afraid of surprise bills. And in fact, 38% of all Americans do this. And two, providers waste hours chasing down coverage information and constantly worrying about whether the payer is going to pay or not. I think we all feel it. This problem's getting worse. The problem's getting worse because insurance is getting more complex over time, not less. And this further erodes trust, and we see it everywhere. At Nirvana, our mission is to restore trust in healthcare by answering these two questions confidently and accurately. And so the whole purpose of our product is through AI, we tell you if you're covered and how much the visit will cost you. And so as a result, patients can access care with certainty, providers can deliver it without friction, and they can also save time and headache dealing with insurance companies. We work with providers across all types of care, from mental health to radiology. And specifically this past year, we also made a huge investment in expanding our product to support Medicaid populations where complexity is going up and resources are going down. Medicaid is needlessly complex, and it's hard to understand if you're eligible, and it confuses both patients and providers alike. And frankly, with new legislation, the complexity is only rising as a result. At the end of the day, no one should have to forego care because they're unsure if they're covered or afraid of what it might cost. Opacity breeds distrust in our healthcare system, and it brings care to a halt. Our fundamental mission is to fix this and reestablish trust in our healthcare system.
Fantastic. Well, that's great to hear, Kelvin. And yes, the Medicaid situation is getting more complex and somewhat more desperate. And it's going to especially be next year after these cuts start coming in. So I think that's one of those things where we're going to really discover, what's going to be a useful service that technologists like you can provide to both providers, but also to the patients, of course. And yes, that population is in for some surprises, unfortunately. Okay, right. Our last company in this health equity space is Access Telecare. Chris Gallagher is the co-founder and chief strategy officer. So Chris, please take it away.
Thanks, Matthew, and we're thrilled to be included here. It's awesome to hear the stories being told, and just consideration as a finalist in health equity. Access Telecare is the nation's largest provider of acute care telemedicine. We're founded around the concept that timely care changes outcomes, and so we're a clinical services tech-enabled organization that works with hospitals to bring tertiary level care to any hospital in the United States. We do this by bringing virtual physicians, virtual nurse practitioners, and PAs to hospitals through our proprietary technology that can be integrated with existing infrastructure at hospitals. And so we have 8 core specialties that we bring to hospitals to assure that the patients don't have to transfer. They don't have to transfer by ambulance. They don't have to transfer by helicopter for a higher level of care. They can receive that care locally in the hospital or emergency department where they presented. And our organization has now treated and had 8 million video encounters since inception. And in 2025, we'll have over 1 million video encounters. Our organization works in all 50 states across our 8 specialties. We now serve 15,000 US zip codes with care when it comes to the zip codes our patients call home. And this represents just at 65% of the United States, or roughly 215 million people. 83% of the patients we cared for in the last 18 months are underserved. They're either uninsured, they're Medicaid, they live or reside in a health professional shortage area, or they're elderly. And really that aligns to our mission, that timely care changes outcomes. We know that when patients receive the care they need, when they need it, their outcomes improve. And so our mission really can be summed up in 3 words, which is care to patients whenever they need it, wherever they're located, and whoever they are. And really appreciate, again, the opportunity to speak about our organization and share what we've been doing for the last 2 decades.
Thanks, Chris. So we're gonna. I don't know if we've lost. He's. We may have lost him, but no, he's back.
I'm here.
Oh, you're back. I thought you lost it. That's good. So we've got a good long. As I said, some of the other sessions, barely people had time to tell you what they did, and then they were off. But we have a good long time to chat. So, Kirk, I want to turn it to you and just fire away with some questions about how you think this group is dealing with the whole question of health equity.
Yeah, I think many different angles on how you address it, and health equity is not a simple single solution to handle it. And one of the big questions that I love to hear from you guys, and Matt, I'm hoping this is my free reign to fire questions for people to answer.
Absolutely, you're in charge.
Yeah, I always say that in healthcare and innovation, you got to be a little crazy to get in healthcare, because you could do anything to make money. Why healthcare? And then why even health equity? And so one of the overarching questions that I would love to know is, why, of all the things, did you choose to have a focus on health equity? And what's the personal connection to the company or solution that you have created?
I'm happy to start, Kirk. So for me, I think the journey started pretty personal. So I'm originally from a faraway country named Israel, which, like very many other European countries, have a very social healthcare system. I used to work in medical device, so I had some of that tech background. But then I was a caregiver for 6 family members with cancer, my parents and 4 others. Kind of started to create an itch, and I was looking for a problem that I'm not only passionate about, but I can see how it can scale with a meaningful business model, which is something that was very hard to find in the early days. I was shocked to see how hard it is to get access to what I took for granted. So my family had many different hardships, but they weren't related to the financial one. And when I saw the gap in care that patients have here, because of the different structure of health insurance coverage, and the very complicated dynamics that we won't get into today about payers, pharma, administration, and so forth, I found that it's not only a critical problem that is worth solving for, and the passion that I had personally, it is one that, if done right, can really create a win-win-win financially, which I think is critical, to your point, to be able to scale solutions. I don't think that we would be able to reach around $10 billion of assistance secured for patients if it wasn't something that doesn't only help patients, but also their care providers, and different ones that are scattered around the country without access to most of the funding that some of the big centers have. So I think that that's where kind of the personal story started for me. But it's interesting to see that while we started in a very niche part of the industry, to be able to be pulled away from it and expand to all conditions, all sites of care, and then now break other barriers that are not only affordability, still kind of hits really close to home for why we started from the very beginning.
Cool. Thank you.
Kirk, I'm happy to go next. So our organization, I think kind of like a good highlight story here of why health equity is, I think, goes back to one of our first, which was building the first virtual ICU in Texas. And the very first virtual ICU in Texas was built 70 miles outside of Dallas. which is one of the largest metro areas of the United States. And the hospital we started it at was 100 beds, had a 10-bed ICU that ran an average daily census of 2. And the number one reason a patient transferred by helicopter or ambulance out of that hospital was for critical care. It had a recent renovation, had a beautiful ICU, had all the nurses, had all the pharmacy, had all the technology to do the imaging they needed. What they lacked was critical care doctors. And 70 miles away, we tried to recruit and help the hospital for 18 months. Only one physician interviewed, and no one wanted the job. And so the standard became what the standard is, where there isn't access, there's access issues, patients were transferred. And so it led to us building the first virtual ICU in Texas. And within just a matter of months, the ICU census went to 8.5, so increased over 400%. And critical care dropped from number 1 to number 16 as a reason for transfer in the hospital. And that was 12 years ago, and that continues today. And so from our standpoint, really that first experience opened our eyes to this is a microcosm of a much broader issue that can be solved by bringing patients to the doctor rather than moving patients to different care settings. And for us, that's I think 2,600 programs later, it continues to be our mantra going forward.
Cool, thank you. I'm curious, which direction away from Dallas?
East.
East. So was that Lufkin? I'm not Lufkin. Longview, Tyler area?
You're very close. Sulphur Springs, Texas.
Yeah.
Very close. Yeah.
My early days, my first iteration of pharma, I had all of East Texas through San Antonio down to the Rio Grande Valley. So I know that area pretty well.
Yeah. Lots. Not a very far drive, but
no,
lots of underserved areas.
Yeah.
Yeah.
I can add and just build on kind of what was said, give a personal example and then also a company-wide perspective. As a physician, I did my training in California at Stanford, and I had the privilege early in my career to work at the county hospital, and every day saw the effect of the issues of lack of access, of delayed care, in terms of just people coming in where they have very severe, serious illness that could have been prevented if there was access earlier on, and if they had a care provider. And sometimes you would just be like, wow, that's really tough that this person had this condition, and if we just push this up half a year, push this up 1 year, their outcomes would be totally different. And so central to my experience that has guided my thinking through the years is how can we get people in front of those care providers in a timely, we always talk about like right care at the right time, but the problem is we can't get the right care at the right time. And so how can we do that in a better, more efficient way that is scalable? And I think that's really kind of from Cylinder's point of view, we know that digestive issues affect a huge amount of the population, and yet we always talk about the folks with digestive issues as kind of like socially stigmatized, because frankly, nobody wants to talk about poop. You were talking about this, Matthew, before, even though we had a sweatshirt on it, but it's embarrassing. We talk about this being kind of like where mental health was maybe 10, 20 years ago before COVID. If there was one silver lining in COVID, it's that we realized that everybody has a mental health issue or somebody we know, but still people can't find a safe environment to talk about this. So from a company perspective, it's really what we see is that we have the privilege to take care of large national providers, employers, health plans. They run the gamut of kind of white collar employees. They run the gamut of folks who are working in warehouses, who have very limited access to, lots of types of healthcare. And so really from the get-go, we knew that in order to do this and do this well, we had to address some of these equity issues and make sure that we develop a product from the beginning that is culturally sensitive, that is language appropriate, that is health literacy focused, that is, all those things that you can think about. If you don't build that in, that people could access, whether that is through the internet or through their phone or whatever it might be. If you don't build it that way, you're not going to be able to take care of a lot of folks. And so we're excited about that. We're able to, with the way our model that we see now, we're driving outcomes is getting people, managing them upstream so they don't end up in the ED, so they don't end up as inpatients, right? And so we've moved upstream and been able to help them in this kind of digestive journey.
Cool. Thank you. Thank you. Thank you for your answers. I think, those for any tech, when I work with founders that I coach, I always want to remind them that they're one of their patients on the other end of the technology, and that the story as to why you're doing this also really matters. And so I think out of all the different digital health and innovative tools, I would never shortchange yourself by missing the connected tissue between your personal story and the solution that you've created. Tangential to that, shouldn't say tangential, but I would also like to ask, how has the way that you talked about health equity changed in this current environment that was so different from maybe 8 months ago, 8 or 9 months ago? And so as you were talking to health systems and as you were talking to investors and people in the general public, maybe speak to how you've had to either modify or change or evolve how you phrase health equity in this discussion, because it is in this current environment like a new four-letter word. So maybe talk about how you've had to evolve your discussions as the work you're doing had to change, but how you talk about it definitely has, given the environment.
I can combine both questions in a very quick answer. First, I'd have to add, I have tremendous respect for the physicians in the room and the providers here. I think in some really weird way, I exist and our company only exists so that physicians and the clinical providers don't have to think about insurance. And so I think tying my personal story to this question, Kirk, and I think it's a great question. At the end of the day, I was born to two immigrant parents who didn't know English very well. And so I spent most of my childhood trying to convert and translate complex health insurance concepts as a 12-year-old so that they knew which one to choose. And I thought it was a function of English being tough, but frankly, as I got older and my English got better, I realized health insurance is just really confusing, even for the most literate, even for people in healthcare, even for trained billers, it's confusing. And so it's become the number one thing I've decided to solve. And we started a whole company purely dedicated to just making it as easy to understand as possible. And that's been how we think about our contribution to healthcare access.
Yeah.
As far as how that's changed over time and how we talk about it and how that's evolved over time, I think fundamentally we work with a lot of back office groups with provider groups. And I think the way we think about health equity is also from the lens of health access and how we tap into other populations, right? You can accept, for example, you can accept Medicaid, but that doesn't mean it's easy for Medicaid patients to find you. They might not know you take Medicaid. They might not know you take Medicare, right? I think it's very easy to think of the payer contract and immediately assume every patient, that means patients are just going to come in through your door, right? The reality is if you sign up for health insurance, a lot of people don't know if they have Medicaid. A lot of people don't know if they have Medicare Advantage. They sign up for a United Healthcare plan. They see that logo and they think, yes, I must be able to see all these doctors, right? In that one logo alone, United Healthcare offers a Medicaid plan, a commercial plan, an employer plan, a Medicare Advantage plan. But the everyday person doesn't really think about those distinctions, those nuances, and they're lost in the system and they don't know how to find their way to providers. And so for us, I think it's very common in the cultural zeitgeist today to appreciate the complexity of how hard it is to navigate insurance. That's always been the case. But I think connecting those dots with providers as a mechanism for how they expand the types of patients they can see has been definitely a way we've evolved our language.
Cool. Thank you, Kelvin.
Kirk, so on that question of equity and just kind of like how we're using the terminology, our organization a few years ago came together and said, how do we want to define quality? And everyone within the organization had like a slightly different definition of quality. And so the way we standardized was around the NIH's STEEP framework, which was published in 2001. And STEEP stands for safe, timely, efficient, equitable, effective, and patient-centered, right? So back to 2001, equity was like center of this before it was kind of politicized. So we've really kind of rallied around that as one of the quality markers is like how are we developing equity within the programs we build, and like we measure and manage to steep in every single one of our 2,600 programs and over 1 million patient encounters this year. And so, but when we talk about it outwardly, we've used the term more of accessibility, because I think everyone can agree, like we want accessible healthcare, and that kind of goes across all strata of socioeconomic challenges, race, demographics, whatever you want to say. Everybody wants accessible care, and I think like that's what we've really been anchoring on as we think about just something that wouldn't be polarizing, wouldn't be a lightning rod in terms of a term.
Yeah. Cool. Thank you, Chris.
Maybe I can add a little bit. I think, as you've mentioned, Kirk, the environment kind of has changed, but our approach hasn't changed in terms of like what we really care about is the outcomes that we drive, and that means the outcomes for the whole population that we're taking care of. And if we are going to do that and do that well, we need to know what the issues are for the populations that we have the privilege to serve. So, and as we all know, things like social determinants of health are like at the end of the day, even like drive the majority of like outcomes. Like, when they look at research, what we do is say in a doctor's office is a piece, but if they can't get access to food, if the health literacy is poor, if there's like all those things are critical in order to drive the outcomes that we want. So really our approach is we need to create and sustain and implement a service that is sensitive to health equity and disparity concerns, because that's the way that we're going to drive the outcomes that we seek, right? And so from that perspective, it doesn't change, right? In terms of the approach that we take, the way that we build the product, and the way that we deliver our services.
Yeah.
The last thing I would add is I think drug costs, is top of mind in the previous administration, in this administration. And I don't think that like equity from that perspective has been a polarizing issue. But what we have noticed is that whether it's through new legislation coming in, or even like chatter from the administration about what is going to be new kind of policies, or even like the one big beautiful bill that is creating an immense amount of pressure for health systems in terms of Medicaid reimbursement, and just like the pressure altogether, all of those tailwinds and headwinds don't really matter for patients, but they're caught in between. And then when there is so much hesitancy from one part of the ecosystem and reluctant to like act on something from another part of the ecosystem, the patients are the ones experiencing the widening gap. And I think that's where companies like the ones here have a role to play, and figure out how do we make sure that they don't fall between, where those big forces with different interests are sometimes just like overlooking the fact that the patient cannot access the critical care they need. That's the way we are approaching it. And like, unfortunately, when there is a lot of noise out there, we can actually come and navigate. That's kind of what our software has been able to do in a lot of those cases.
Fantastic. Thank you. Matt, how are we on time?
So we're good. I think one more from you, Kirk, and I have a lightning round question we'll close with, but you can dig in one more, I think.
Yeah, fantastic. Yeah, I'll just add real quick that all the answers were great in different perspective. For Together Health, we had a health equity subcommittee that we had a public pledge. We had health systems, won't name, and the health systems that participated, but we had a public pledge on our website. And then at the beginning of this year, many of those organizations had to remove their name from the public pledge. And that began, some of us having to think, how do we do the work, and what do we call it now? And how do we, still be very passionate about the work, but have to be judicious and prudent in how we talk about it. And so I actually have worked on this concept called the healthcare arrow, which is access, research, risk, outcome, and workforce development, which talks about a lot of the things that we're trying to solve anyway. So I think that people are being more accepting of being able to talk about it, because we still have to do the work, right? Last thing I'll just add, a question I'll ask, health equity in the United States and the problems you're solving are directly tied to a lot of the global problems that are also evolving or existing in other economies and developing nations. And my new role with Together Health is overseeing our international expansion. So I would like to just know, as you look at the work that you're doing, are there any international countries or connectivity that you think would be kind of the next step outside the United States that you think you could also solve a problem for another country or another population outside of the United States?
Happy to jump in. So I think as we think about our workforce, so we're delivering clinical services that are tech enabled. The two most common languages are English and Spanish. And so as we think about where would be a natural place to expand, well, our provider base, they're interfacing with patients through our technology. Those patients are hospitalized. And so having fluency in the language and being very agile and in discussing, very critically important situations and diagnoses, like those are areas as we think about. So from our standpoint, English countries where there's common English language or Spanish speaking, those are areas we've been considering.
I would just piggyback on that. Is that the same kind of thing in terms of English, Spanish? Obviously healthcare systems are very different across countries, but I would just say, for example, the clinical protocols that we use to deliver care, a lot of them are, from international guidelines, whether that is NICE in the UK or otherwise. And so you can see that the care, the protocols are kind of like world standard, if you will. And then the implementation obviously is dependent on each country. But similarly, based on a language type of framework, those are the countries that we would consider in the future.
I think from our perspective, obviously it's easier, well, not easy to translate clinical and diagnostic solutions into other countries where it has to do with like the intricacies of like how reimbursement and policy is built is a little bit harder. But when we look outside of the United States, I think we look at underserved populations where there is access to care barriers that are like pretty profound. And then I think two paths for us that we started exploring that is one, through research. We actually been approached by like a group out of Nigeria that are like looking at financial toxicity in their own kind of domain and to figure out how we can adopt models and technology to support there. In those cases, we're very happy to support research and like provide our expertise and tools. And the second one is actually through pharma. Because one of the things that we've seen over the last couple of years, once our network reached critical mass, we started bringing pharma directly to support patients across our network, and you work with market access teams. Those market access teams are part of global market access groups that are exposing us to the different ways we can actually innovate with different types of models outside of the United States, which will probably be a few years out because there is so much more to solve here before we can actually afford kind of defocusing, but definitely that's the way we think about it.
Yeah, fantastic. Yeah, I'm sorry, Kelvin, go ahead. I forgot one more.
Obviously, the U.S. healthcare system is pretty unique in terms of insurance, but I think rising costs is not unique to the U.S. There's an aging population, healthcare costs are going up everywhere, and the interesting seesaw of health insurance generally in the whole world is as you have higher costs, you create more rules to manage it, and that's never going to go away. That's just how insurance works. So you create more rules to manage costs. Now the question is, how do you responsibly create rules? And I think the most interesting part in perspective that we have is we've seen millions of different ways to construct rules. And as we've seen in society, as we've seen in the US, you can create rules that are overly burdensome and way too tough for the patient and provider, or you can create rules that manage that delicate balance of managing care responsibly. And where that slippery slope is and where that line is, it's a really hard qualitative judgment in many cases. And so, but we see this throughout the world. There's rising supplementary health insurance companies, even with ones that are single payer, partly because healthcare is just skyrocketing. And as we continue to work across health insurance, I think it will be really interesting, and we hope to be part of the conversation in terms of how people design new and more responsible and ethical ways to manage care.
Yeah. Yeah, I think that's, all really insightful, unique perspectives. I've the last couple of years been doing a lot of work in Latin America and in Panama and Colombia and Chile. And what's interesting is to see in some of the Caribbean and Latin American countries the growing trend for medical tourism that is bringing some of the innovation to help support the very high end top of the food chain. But at least that is bringing some of the infrastructure that eventually will help some of the underserved, because there really isn't a middle class in some of those countries. So I think there's a huge, opportunity there. I think, and I can't remember if it was Chris or who was talking about Shirley. Tell me how to say your name again correctly, because I don't want to mess up people's name.
Sully,
Thank you. Shirley. I think, you can't deny a lot of the data on the evolving population in Africa. And I forget all the statistics, but the number of something like Africa is going to have the largest segment of people from like 20s to 35 in the next year, and all of their growing needs, because there's this new growing middle class across an entire continent. So you look at, Nigeria, of course, you look at Kenya, you look at South Africa, you look at Ghana, Sierra Leone. There's a significant amount of opportunity there as well. So I would just encourage each of you guys, as I talk to a lot of healthcare companies in general, to not think of yourself as a US company, but a global company, because if you can solve the problem here, if you can solve it for more people across the world, it just is a bigger pie, more patients that you're going to be able to help.
Fantastic.
Then
So,
Matt, back to you, my man.
thank you, Kirk. I mean, I think those are wise words. And I want to end us on a note of optimism. So, yeah, we've had basically a sea change in the US and how we think about health equity, as Kirk said. I'm in the camp that, you can pretend that something's not a problem, but it's still a problem. Doesn't mean that the problem goes away. But I want us to end on a little note of optimism. We've had a lot about the issues involved in health equity and the problems we have and the rest of it. But you're all bringing technology to bear. And in many of your cases, the technology is sort of delivering us, it's getting us away, it's solving some of these problems around health equity and around other issues. So we've heard a little bit as well in the last sort of year or two about the concept of abundance. Does AI and other technologies get us to a place where, we have abundance and have to manage abundance rather than scarcity, which is what we've really been managing for the last thousands of years. So really quickly, just before the lightning round, this is like 5-second answers each. How optimistic are you that technology and the kind of things you're doing can fix some of these problems rather than just sort of be a band-aid that alleviates them? So I'm going to quickly go around. Chris.
Highly optimistic.
All right. Calvin.
Very confident. We make it easier for people to find care.
All right. Shirley?
Mildly optimistic. I think there is also an inherent risk with AI that it will widen the gap for the underserved. And I think that we need to be very cognizant of that. So not super optimistic, but getting there.
And how?
Yeah, I would say I'm optimistic. You have to have the right guardrails in place, but to be able to identify those gaps and act on them, triage, and get them to the right place at the right time, I think there's real potential there. So guardrails for sure, lots of potential.
Fantastic. I think, my viewpoint is that there's an awful lot that should change and could change, and that, really what's going to have to help it happen is people like you and people like us all promoting it and saying, how can we make this better? Because there's clearly a vision for how we can do things. And even it's just, allowing people to be treated in the community they're in. Chris, as opposed to having to drive 70 miles into the hellhole that is Dallas. Have they sent federal troops that year? I'm not sure about that yet. You can understand that there are little wins that can up to big wins. And I think that's really what we have to push in this era, where we can't call it health equity or whatever, but we'll call it health equity. All right. With that, we are done. You'll see all of these fine people on stage, actually at 3:40 p.m. Monday the 20th on the awards pavilion stage, where we will actually have the winner. You can see that the Digital Health Awards are going to be in 4 separate stages. This is the 340 one. That's the blue. It's the second from the bottom right, blue stage, where Health Equity and a few others will be there. Kirk and I will be there with these 4 gents to hand out the prize, and there'll be some other great stuff as well.